how do we mobilize additional resources for health. This time around, we are looking at innovative financing beyond SSP. We are looking at what are the additional earmark accounts at the national and state level. How do we mobilize resources from the private sector and trust fund, including other innovative approaches as well. And we know that financing will be more political than technical. We look at how do we take advantage of the policy reset window that comes with the election as we approach the 2023 election. We'll look at that as well. The first panel started and built heavily around public finance. Now we have to start with private financing this time around. And we're very lucky to have a private sector health alliance here, doing a very, very great job looking at how to mobilize private resources. Dr. Han, we have not been able to fully tap into the private sector resources to finance health in Nigeria. But the experience of COVID tells us that it is possible. Because during COVID, we were able to mobilize a lot of resources from the private sector. And the question to you is that the organization, what are you doing? What model should we use in a sustained manner to mobilize private sector resources to bridge resource gap in the health sector?
Many thanks, Dr. Gafar, and it's a pleasure to be here. Good afternoon to everyone. So in terms of tapping into resources from the private sector, one currency that's very important is for us to continually build the trust that is currently eroded between the public sector and the private sector. We seem to have a lot around the issue of trust, accountability, ensuring value for money, reducing wastages and plugging leaks in the system. For private sector, because we're very much driven by value for money, ensuring that every dollar or naira contributed to the health sector counts and makes a difference. It's important that if the public sector is to tap into business with the private sector, they need to demonstrate a high level of accountability. There has to be a demonstration of proof of concept that whatever we're going to put these funds into is targeted at producing results, is targeted at improving health outcomes for the poorest and the most vulnerable Nigerians, is targeted at equity and ensuring that across the divide, we speak to the emerging health trends that you can see that our pattern of health care or needs across the health sector is evolving. So if we must tap into resources in the private sector, we have to be looking at some of these issues. It's also important that we bring evidence to the table in terms of resource mobilization, because for private sector, most of our investment is driven by evidence real time. So we need to see where the needs are, that these needs are clearly demonstrated, there is proof of concept, and that funding gap is backed by evidence as driven by data.
Okay, thank you very much. Are there specific model of what private sector health alliance is doing now? We know all those best practices are very important. In terms of a specific model of how you are collecting money from the days of this world and the Mobian and all those, what model are you using and what can state at the national level learn from that to bridge resource gap?
So some of the projects that we have carried out, our biggest project currently is the Adopt the Healthcare Facility, primary healthcare facility, which is adopting one primary healthcare in each of the 774 local government areas in Nigeria. How are we financing this model where we're mobilizing resources from the private sector and supporting government in the public sector to ensure health access is improved? What we simply have done is to demonstrate a need. Private Sector Health Alliance is a bridge builder between the organized private sector and the public sector. So what we have done is to demonstrate proof of concept that there is a need in the public sector at the primary healthcare centers, because we believe that primary healthcare is the foundation of improving healthcare and achieving universal health coverage in Nigeria. So we have gone back to the private sector, we have done a baseline analysis, we have a tangible product that we have shown to the private sector, and we have shown them the reason why they need to invest. So we have adopters, philanthropists, well-meaning Nigerians, high net worth individuals, HNIs as we call them, who have demonstrated interest in adopting this health facility. So they're partnering with government through Private Sector Health Alliance to be able to provide healthcare to Nigerians who need it in some of the most difficult terrains. That's one model that we have used to bring private sector contribution to public sector. Something else that we have done is also to get the private sector to see through small projects that we have done, the Nigerian Healthcare Innovative Markets, where we have done small pilot projects in communities. We have demonstrated that these work, and now we have philanthropists, we have high net worth individuals, we have companies who are willing to now put money to improving healthcare, outcomes. We are also working with banks to provide financing at low cost to private sector individuals or private sector organizations, and this has helped, to provide financing to improve the quality of commodities, healthcare commodities, that come into the market, so that we're not importing a lot. We're also reducing imports, and then we're reducing costs. Maybe lastly that I will speak about is we have also been able to work with the private sector so that some of these investments in the health sector can be reported and they get tax holidays from it. Because for the private sector, there has to be a reason why they're interested in investing in the public sector. So what we have provided for them is a platform that allows them to report expenses on health in Nigeria, and they're able to enjoy tax holidays from their expenditure on health before tax.
Great, thank you very much, Dr. Hada. That is very helpful. So I'll go to Dr. Lukate now. As we discuss additional possible earmark funding for health, I think it's very important for us to learn from the existing ring-fenced funds. At the national level, we have the Disease Acquisition Fund. At the state level, we have the Equity Fund. Dr. Lukate, as one of the stakeholders that is very involved in the design and supporting at the national and state level in the implementation of this earmark fund, what lessons have you learned that should guide future earmarking of funds for health? Dr. Lukate.
Thank you very much, and thanks a lot to all the organizers for inviting me to this very important dialogue. So I think just drawing from the conversations we had earlier in the day, I remember the DG budget mentioning and I think also the experience from Ghana, talking about earmarking is one thing, right? But then when we earmark, and this is what we've been experiencing in Nigeria, when we say we're earmarking 1% of the consolidated revenue for the DHCPF, now that money, first, does it eventually get released? Because it's not being earmarked in policy or by law, but does it eventually get released? Now, the more importantly is what is released, does it get utilized? Does it just take the account to having very sad situations like returning 6 billion naira when we're actually complaining that we don't have enough? So, the big lesson with earmarking is not a silver bullet that solves your problems. The funds that are being earmarked, have you thought about how those funds will be collected and transferred? So if they're earmarked for health, how does it go from finance to health? Does it actually get released to health? When it gets to health, how does it get into life? Have the systems and capabilities been built to utilize that money? Because it deflates the system and all the stakeholders when after all the advocacy and compromise, we get the money and it doesn't get utilized. So have we effective. Money is easy to spend until you're looking at spending it effectively and efficient. Then you find that a lot of times you start having delays. So as we think about the market, we should look at the fact that just taking BACPF as a clear example, how much releases have we had since 2014 to date, and of what has been released, what has been the percentage drawdown. So the big lesson with the market is the market is not a term that solves all the problem. Even if you go all the way to fencing and all that, have we deliberately developed the capabilities to implement? Now, just quickly before I move away from this, on the SSB tax that we implemented, we had a roundtable discussion with our colleagues from the private sector in the Nigerian Economic Survey. Some of those who are traditionally opposed to any additional taxes, be for health, education, or anything. And one of the things they raised is why we're focusing on SSB. There is a tobacco excise duty that probably generates more money than the SSB. And I do remember that earlier, a few months back, the Minister of Finance actually announced that the implementation of the increase in the adverent tobacco excise from 20 to 30% will commence 1st of June, which is last month, and run for 2 years all the way to 2024 before it's reviewed. How much money are we looking at? How does that play into this conversation around additional money to be earmarked? So just like the previous speakers have mentioned, so we don't lose focus on the bigger picture because we're looking at the market person. But like I mentioned just to recap, the market is not a silver bullet. When the money is earmarked, have we actually built the capability, the frameworks to utilize the money, account for it, demonstrate results, and demonstrate that the marketing, getting additional resources for health and the marketing and investment actually makes any difference. Thank you, Apostle.
Okay, thank you very much, Dr. Nkata. Before I go to Dr. Aribabu, you mentioned a lot of important points, but I want you to emphasize something. You talk about demonstrating a result with the funds. That's the big issue that we've been discussing. In your opinion, when you get SSB, when you get even from the basic care provision fund, how do you think the health sector should be demonstrating the result that this money is making a difference? Dr.
Okay, so yes, thank you for that one question. So I think we've done a lot of groundwork. We've laid a lot of the foundation that at this point, building on it and demonstration results should be easy. The first thing, which I think for me is one of the biggest victories of the BACPF, is the fact that we have defined a package of care, right? Because it's difficult to measure when you don't have a defined package or a defined product or service that you want to do. That's one. The second one is just looking at delivering services to people. Any additional resource to the sector should not start going back to funding increase, getting kicked off by administrative charges and all that, but to actually looking at how many more Nigerians, right, can this deliver that minimum package. And Dr. Bimidor of the World Bank, the Commissioner alluded to that. How many more people is so even in a state that has a state health insurance scheme and has 100,000 people covered by the health insurance scheme receiving a package of care. When they get BHTPL, how many additional lives is BHTPL bringing in? If you give them money from SFF, you sum up state health insurance, BHTPL, how many more lives is SFF? So that we can actually tell that we are adding up. Otherwise, what we're going to have is the funds become fragile. Money comes in from SSB or from tobacco, state withdraws some of its original budget or the federal. So you stay at the same point, but then you just keep throwing more money in. So the easiest way really to track this is to look at outcomes, not to be measuring it with how many more buildings have you put up, how many more vehicles and ambulances you do by, how many more people you do, but actually to look at how many more Nigerians are receiving care. Thank you very much.
Okay, great. Thank you very much, Dr. Nkata. says that more Nigerians access healthcare from the private provider than the public provider. So from the private provider perspective, how do you think available earmark funding will be better be utilized? What do you think should do, the policy maker should do differently?
Thank you very much. Statistics available show that between 60 to 70% of the healthcare earnings and patronage provided by the private sector. Incidentally, this is the sector that is representing the eye of the supply side. In which case, assuming governments have gotten enough healthcare facilities that is public driven, fantastically driven, perhaps the private sector will be less needed, just as is happening in Rwanda and a few other countries. However, this is also a sector or a group that I would say is experiencing competition rather than collaboration. And there's a difference between the two. If the private sector, I would say, is helping to work out this adequacy on the supply side, what they need actually is collaboration. Issue of energy is not there. It's epileptic. There are other social infrastructure that this supply side, the private sector, ordinarily would need to be able to add quality to the care to be assessed by the enrollees, for example, or the end users. However, while we are thinking of innovative heads, innovative options to make sure we bring in funds, I've always looked at it, what my Ghanaian friend described as a melting point. I call it the sausage roll, or the common pot, or what we call, usually when you go to Bukateria to eat or restaurant, you say, give me assorted. So when these things are put in a pot, it's a common pot already. So it doesn't now really matter who contributes to the pot. Everybody bring plates to just take your dish. And whatever you get, well, kill the elephant. People come into court, and the author who has going to kill the elephant will begin to wonder whether that was the purpose of going. So I think there must also be audit of the tax collection. You see, for you to appropriate to say, okay, how best do we think it to be done? There are sharp practices, and you will not believe it, both from local government to state and to federal. I was at a taxi park somewhere, a particular airport, I don't want to mention it. The taxi man that carried me gave me something that looked to me like inflated amount. And he said, okay, 1,000 of this amount to go to Susu, the wife of Susu minister. I wouldn't want to mention. And I said, how? He said, that is their own tax that they do. Then their boss who was there was like, that is it, okay, it's 8,000 will carry you from this airport to that spot. It would not have been up to that if not for sure. And I think, we talk about that corporate governance. We have to fight, first of all, issue of corruption before we start taking no distribution and sharp practices. If, for example, what I need to pay as my tax is 500 naira, and if you can do away with you directly with only 200 naira, you tell me to pay 300 naira. So we have an agreement from the base. They even want to go to call me, it's not budgeted. So having said that, I think if for any reason we look at giving grants or loans that are given at single-digit interest rate, for example. So, in fact, we pump it into the private facilities or private health sector, let me put it that way. I think the end users who are going to pick up the bills, for example, since we still say 70% or more is still out of pocket payment, they will feel relieved. Just like this sugar beverages that we're talking about. Whatever you push in, or you want to cut out from the producer or manufacturer, they will pass the bill, the extra bill to the consumer at the end of the day. Ditto with whatever is happening to us at the health sector. So what we need to do really for the consumers or for the end users to enjoy maximally from the supply side of the facilities, for example, is one, we have thought of it. Can we begin to think of, even the 5,000 naira that were being given to some 40 million